Welcome to another episode of HR the Leader podcast. And this is the last episode for this season. And I'm excited to bring back Carrie and John because we set it off in part one. We're going to set it off again in part two. What we're talking about, volume-based versus value-based medicine. And since we are respiratory therapists, we're going to go ahead and apply that to respiratory therapy. Carrie, go ahead and say hi to the people.
Hello, my name is Carrie McClure, and I am a clinical supervisor in the metro Atlanta area. I have a bachelor's degree in respiratory care and a master's in business administration. My background is in ICU critical care, emergency room, neonatal intensive care, and labor and delivery. And I started in leadership in 2021, and I love it. It's my favorite thing.
Good. John.
Thanks, Hans. John Fisher, registered respiratory therapist, EMT as well. Got my degree in cardiopulmonary science. Most of my time at the clinical bedside was predominantly children's pediatric hospital. So mixed variety of different roles, from clinical education to full time with air and ground transport. So definitely excited to be here and continue with on from our previous episode talking about value and volume based care. So thanks again for this opportunity.
All right, let's get into it. Part one, we exposed the problem that we can't continue the way we are doing it. We talked about it. Everybody now is thinking about it. But how are we going to help the leaders? How are we going to get the feel? Some tips in part two to actually start moving and having better conversations to move from a volume based, task driven into a value based. At first, it comes from the top, it comes from us, comes from the leaders. First question for the team. What mindset do we think leaders must shift from to start shifting from task based, volume based to value based? It comes from us. So, as a leader who's probably listening to this podcast, give them some practical tip to start at least shifting their mindset from what we've been taught, more patient, more volume, more task equate productivity. So let's go ahead. Let's tackle that part.
So I'm going to say empowering them to use clinical judgment. Of course, we want, to use protocols. We know that protocol based therapy produces the best outcomes. But, value based care is, right treatment, right patient, right time. And, we want leaders to empower their clinicians to use clinical judgment, know when you need to go by the protocol and know when you don't. Know when the protocol is no longer applicable or when something is not indicated.
So, anything, John, you want to add to that?
I think it's a top down thing, right? I mean, we're not going to have a culture change happen with a flock of new grads coming out of school. But the flock of new grads are absolutely influenced by the environment that they go to work in right out
Yeah,
of school, right? So, I think that leaders, whether that be the clinical educators, whether that be supervisors, whether it be department heads, there needs to be an incentive to not focus as much on what you're doing, but why you're doing it, right? I mean, I think that's what protocols are, but unfortunately, there's always that off protocol. Like, well, this
yes,
doc wants to go off protocol. I'm like, man, what I want is a world where RTs are called to evaluate, not called to do. And I think that's a top down approach that is only driven from within the leadership.
absolutely.
So, one of the questions that we talked on at the ARC is we are actually excited about moving towards value,
Hmm.
but how do we transition from our organization still looking at volume because we need the volume. We need people to show up. So is it to have a good mixture of volume and value, or how can we start making that change? How can one clinician or one department be the trendsetter, and what would be the best step to start that movement?
So when you're saying volume, we're talking like productivity, right? So I productivity matters for sure, but that's not the whole story. And there's needs to be a second question. And
Mhm.
doesn't need to be just how productive were you, but what happened because of that productivity. So that needs to be two parts. It needs to be, were you productive and what happened because of it? Because that's where the value is created, is in what happened. So, I think it's important, but it's incomplete.
I like that.
Yeah.
It's were you productive, but what happened when you're productive? Oh,
Yeah.
this is good. This is really good. John, what you think about that?
Yeah, man. I mean, think about if cardiology was only evaluated off of how many cuts they made, right? How many incisions they made.
Mhm.
Or, think if for instance, if they were only evaluated on how many EKGs were done, right? It's the full procedure and the value that they're assessed on, right? All those things are important. Obviously, you need the 12 lead, you got to have the cut if you're doing surgery, but what's the end goal? The end goal is someone's life was saved, right?
Mhm.
And that's why they are you know massive when it comes to the ROI for hospitals. Is they're not being evaluated on necessarily what they're doing, but it's the extraordinary outcomes that happen as a result of it. And respiratory is in the same position, right? I mean, how many areas can we influence? We talked about this in episode 1. It's a slippery slope, balancing. Do we have volume protects us, right? We got to be able to have things to do. But at the same time, we don't want to get rid of things to do because we're running protocols and we're getting patients discharged faster. I think having an overemphasis on the assessment, which
Yes.
what leads to the outcome, and the outcome being a good one. We need to be involved in the full continuation aspect of a patient's journey in the hospital from the ED to the time they go home, not just on task based things, just a treatment. It's what's the result of that treatment.
Carrie brought this up in her first appearance, and I wanted to bring it back. What is the relationship between clinical assessment, protocol, and increase in value? Because now we just had those three. We just talked about all three of them in the same answer. So, how important it is for clinical assessment to be right, and do we follow the protocol to the letter, to the T, and will that have a positive impact on bringing more value to the conversation?
Well, better clinical decision making is going to result in better patient outcomes. I
Mhm.
think that, that's where the capability of the therapist and understanding disease management, pulmonary disease management, and, and trusting their assessment skills is really essential to value-based care. I this is one of the things that we've talked about over and over again is, where are those critical thinking skills going? And, now they need to be empowered to use them, because it's definitely going to matter if we're going to pivot in this direction. What are your thoughts, John?
I mean, I think, this is when you kind of talked to it at first is, how do we get there? I think it starts with
Mhm.
setting the foundation of our departments.
Mhm.
Um, one of the questions that I have is, from you guys is experience at the hospital. What is a check off for when a new graduate is ready to go? Right? They come in, they get hired out of school. What is the check off to say, all right, you're cleared to run and have your own assignment. Go have fun and save some lives. What does that look like for you guys?
So
You want to go first, Gary?
yeah, I'll go first. So, of course, there's the, orientation, there's the computer based
Yep.
modules, a trillion computer based modules that have to be done. There's protocol classes, there's equipment orientation, knowing where supplies are. Then, you get to the patient bedside and there's a whole task list of things that have to be assembled and completed. You know how to put the ventilator together. Do you know how to put the heated high flow together? Do you know how to, do a ventilator assessment? Do you know how to draw off an arterial line? I mean, there's all of these tasks, but the problem is that none of those things tell us how capable somebody is of doing a job.
Bam.
And clinical capability is what is really important. Competency says, I can do this task. Capability says, I know what to do when this task is no longer applicable to this patient. So that's my soapbox on that.
That's your question and your answer.
Yeah.
Hans.
Yeah,
Yeah, Hans,
yeah.
what do you think, man?
While she was giving the answer, then the problem actually came. So, wow, this is what it is. We are
Yep.
we are task oriented.
Yep.
Yes.
So we need to start. We need to shift it from the root. And how what Carrie said is we need to have capable clinician to know what else do I need to do when that task is no longer applicable to that patient.
Yes.
Wow.
Yep.
And you're right. And now going back to what we just talked about, how do we how can we stop time for that transition? It's like we are drinking from water hose. It's coming out at 1,000 miles an hour. Can we say, okay, stop? Now let's reset. Or do we slowly redirect the efforts and redirect how we think in one skill at a time, one value at a time? Because it's still to me, just to play devil's advocate, I think it's a little far fetched for some leaders will be listening to, man, this is great talk.
Mhm.
But right now I'm sitting on 30 events. Right now I'm short staffed. Right now,
Yeah.
this is everything that I need to do, but this is great. But how do we switch that? And same thing for us at the bedside, we have 15, 20 new grads coming in per year, but by the time they get off, we need them to get come off and hit the ground running. So it's how do we start that? How do we pivot?
So, we know that COVID really hurt the capability as far as our profession as a whole. A lot of very experienced clinicians left the field or transitioned to other roles. And so that really put us at a disadvantage, across respiratory care, and not just respiratory, healthcare in general. And, I haven't said this much, but it has led me to wonder or question if it's something that organizations are going to be able to do without funding. With COVID, there was all the money was the system was flooded with money, for resources, but we haven't funded recovery for that. And, I'm starting to question, you know, do we need to fund recovery? Because we need time and resources to build that capability back up at the bedside. And I'm starting to wonder if that's something that organizations are going to be able to manage on their own. So, because you have to have something to build off of. And,
Yeah.
it almost reminds me of back in after World War II, with the Marshall Plan. Europe realized that, they were going to need to rebuild the foundation for, them to be able to be successful. That was a agreed upon thing. And I'm kind of wondering if healthcare doesn't need its own Marshall Plan. Um, I just That's my concern is just having the resources to do what needs to be done.
Wow, yeah, this is a critical junction.
Yeah.
But it has to start though. But in the meantime, I mean, at the end of the day, we can't we can't put a pause on things. So I
Mhm.
think Hans, one of the things is that you're asking is like, how do we do this right now? We can't put a stop on everyday care at the hospital. So where do we start initiating this change? And I mean, I think number one, it has to be expected from leaders that our departments will need to progress. But I think too, I mean, this is a great opportunity to start empowering students, right?
Yes.
Getting involved in respiratory programs is, I think, a great place because you're fostering the future in those programs. We can't, you probably aren't going to change the mind of somebody that's been doing this for 35 years.
Mhm.
Um, heck, man, you might excite somebody at the tail end of their careers. Who knows? I hope so.
Yeah.
But I think if we take the leadership and then we take the up and coming and we really focus in on what's not the right now, but what's the future opportunity for respiratory care, and once those two meet, being that new graduates and becomes an RT, they're seeing eye to eye on what the future is for that department with that leader who's also embraced these things. It's not going to be an overnight change,
Right.
but I think this is you know, keep rowing, right? Eventually, we're gonna get there. And respiratory's behind in it, but I think that we're not too far behind. I think we still have opportunity for recovery for sure.
But I think we also need to agree upon what are we rowing towards?
Yep.
Because, there needs to be an ultimate goal. Like what metrics are we rowing towards? Because in order to know where to go, I mean, in order to start, you have to know where you're going to end. So I think that having a shared goal is for respiratory and moving forward is going to be really important.
Here's the question: who sets that goal? Who sets the tone? Who sets the direction where we need to go?
I think that's gonna depend on organizations and in general, and we talked about this in the last episode about knowing what your organization's issues are and where respiratory can contribute. And, that is gonna require conversations with administrative leadership to say, how can our discipline help solve this hospital's problems?
Yeah, I think another question to bank off that too is just, or more a little bit more granular on it. Where do we not impact a hospital's metrics? You
Nowhere.
know, exactly. We talked about this last
Yeah.
episode, right? Is that, I mean, it's respite. Yes, it's a little bit of shame on us for not seeing these things, but at the end of the day, like, there's also an outside side that you gotta look at and be like, why haven't we been picked up on these things? I mean, we drive so many areas that impact the hospital's metrics, whether it come to length of stay, throughput,
Mhm.
doctor disposition time, avoidable admissions, all these things they talk about every single day. And why hasn't respiratory been like, man, we're in every single one of these categories. And I
But
think,
are we
yeah,
Mhm.
truly embedded in operations? Because that's the key
yep,
is, all of, nursing, radiology, laboratory, care coordination, all these other disciplines have dashboard metrics that make them a part of the operational structure of an organization. How many of us have that? I mean, you know, if you don't have metrics that you're accountable to, then you're not embedded in operations,
hmm
which means that you know, you don't have a choice but to be at the mercy of administration. It kind of, you know, it really puts you at a disadvantage. So your conversations about resources become very different than, say, radiology or the cath lab or, one of those other places in the hospital. So I think that's key. You have to embed yourself in operations.
Yep.
So here's another question I want us to talk about to help a leader who's watching this. How can we help them define value of respiratory therapy department to their CEO or CFO? It goes right along with having the right metrics. So let's just say, you know, um, a leader for respiratory therapy finally gets a face-to-face impromptu with a CFO, with somebody from the C-suite. Say, hey, how's the team doing? What do you need from us? What can we do for the department right now to help you all move in a better direction? Do you think some of our leaders could actually hold a conversation like that with a C-suite leader?
I mean, I think a lot of the responses, unfortunately, in that question are going to be that you're a treatment department, right? We do treatments. We assess ventilator patients, right? But I think really it's going to be from a top down mind shift to say we're a performance operational improvement department.
Yes.
That's the new
I love
mindset
Say
direction.
that say that again, John. Say that
Yeah,
again.
so, we're a performance operational improvement department, not a treatment task-based department, and I think that once we we have to first understand that ourselves. This has to be a growth and empowerment within our own society before we can go have this conversation with anybody,
Yes.
and,
Hmm.
and I think another thing that happens along with it, I mean, I remember when I was a clinical educator, one of the things that the most proud I saw that I ever was in that role was when I saw a culture change happen where RTs were fighting in rounds. Like, no, we're on protocol, right? I mean, or when I had RTs that used to sit back and wait to be told what to do, instead now they're going and telling the providers what they have done, right?
Absolutely.
Look, contrary to what some may think, providers want that.
They do.
Hmm.
Yeah,
Absolutely.
Hmm.
you got one
Get
attending,
it.
one fellow working overnight in the ICU, dude. There's nothing better than having be like, oh, thank goodness, man. We're pumped that we have X, Y, and Z working tonight as RT in the unit, right?
Yes,
They get excited about that
they
stuff
do.
but they also let it be known when it's not that RT that they want, right? So, I
Absolutely.
mean, um, we have an opportunity, but it has to be first embraced, empowered, and motivated from within our own organizations and departments before it's ever going to be appreciated from those above us.
I mean, there is a certain amount of strategic thinking that I think leadership requires now. A manager runs a department, a strategic thinker makes sure that department stays relevant. And that's what needs to happen because we said this last time that there are organizations where respiratory is becoming less relevant. That's not necessarily a reflection of the leader. I don't know the operational decisions behind some of those things, but once again, this goes back to being embedded in operations and the importance of that.
S- So, trying to see how to ask the next question. How can, if somebody's been in leadership for a long period of time, for over a decade,
Mhm.
have they been exposed to that type of thinking, that type of conversation, that type of data? The fact that we are saying that respiratory is part of every operation of of the hospital, some of our leaders probably can't fathom understanding what are we talking about. So, for that leader, can we discuss? a few of those operations where respiratory is embedded, but yet feels silent. So
Mhm.
that's why they don't see the value in that.
Oh
But
yeah.
measuring value. What are we measuring to determine value?
Hmm. I don't. Again, going back to it is what are we preventing? At times, it's the prevention and not the cure. So,
Right.
like for example, with throughput, how can a therapist or a leader of a department understand that respiratory matters when it comes through when it comes to patient flow within a hospital? Because we're just saying that you're in the ED, like the disjointment from the ED to the floor to the ICU to the discharge. How can how can we help leaders see the bigger picture?
Well, honestly, I think picking one specific thing that is an issue and working to solve that one specific thing. And, you know, like take ER admissions. I know one thing that, has become a topic of conversation is soft admissions in the ED, providers that are not really, that are kind of admitting a patient because they're not completely confident in the fact that, the patient could be discharged home. And so they're, not sure. And so they're like, well, I'm just going to go ahead and admit this patient. But, I think that, and then it becomes a length of stay issue because then eventually, their stay increases. I see this frequently in the CHF COPD overlap patients.
Yep.
That is a really difficult population of patient to manage. And you know that patients don't suffer one comorbidity at a time. They're all, you don't have a CHF exacerbation on Monday and a COPD exacerbation on Tuesday. It's a delicate balancing act. And a lot of times, what happens is these patients get admitted when occasionally maybe they could go home. But, the provider doesn't feel confident. So I think picking one thing and showing how you have impacted that one thing, and do that one thing at a time. We didn't get here overnight. It's going to take time to fix, but I think if we're moving that direction, I think that just, taking it one step at a time might be the way to do it.
Hmm.
You're talking about focusing on areas that we're already embedded, but maybe not being involved in that metric capture.
Yes.
Hmm.
I mean, I think that to summarize this, it's only two areas, right? And I think it can kind of bring light to this. There's two areas. I travel all over, the up and down the U.S. Currently, and one of the things that I see ERs and I see
Mhm.
acute care wards are areas where respiratory may or may not be present,
Yes.
right? Where respiratory is always present is the ICU, where the
Mhm.
ventilators are, right? Where
Yep.
our productivity is weighed heavier, right?
Mhm.
So maybe it's a realignment of what weight productivity carries.
Yes.
I think that the ED is an area where we actually have a lot in common with emergency medicine as
Mhm.
respiratory therapy. Emergency medicine also is looked at as a cost center for hospitals.
Yes.
All right. That DRG don't kick in until they get on the floor. Right.
Right.
So I think the ER is an absolute breeding ground for respiratory success because it provides a unique opportunity for respiratory assessments to be ordered, for
Yes.
respiratory evaluations to be appreciated. I think standardizing and protocolizing a scoring system that helps align everyone understands that a 9 means moderate or a
Mhm.
12 means severe. Everybody's on the same page, but it be respiratory focused and driven.
Yes.
And I think it has to start there, honestly, because it's going to be continued to the floor once
Mhm.
if and when that patient does get admitted. The ER is a great foundation for RT, and also where could we potentially impact metrics that are currently being captured within the emergency department? ED length of stay, ED boarding, avoidable admissions. Here's a big one, a real big one. Doc to disposition.
Yes.
There are physicians that are reminded daily of that they need to pick up the pace. They need to
Mhm.
see more patients. They need to get patient their disposition or their decisions to be made more quickly, right? Well, what happens there is you got one or two MDs that are covering, or even in mid-level advanced providers that are covering a whole wing of an ER, right? And then, heaven forbid a trauma shows up, everything comes on the whole, right? So empowering that RT evaluation and assessment to lead to the best therapy, and the best therapy being, hey, at the end of that therapy, a decision can be made, right?
Yeah.
Are we staying and playing, or are we treat and street, get them out, right? So I think that respiratory's ability to lead to that decision faster is already present. It's just us doing
Mhm.
it.
Yeah. And I
Wow, that's good.
standardization piece is super important because I think that and I love the scoring system because I think then there you have a reliable clinical assessment that a physician can look at and say, okay, well, this patient came in as a 9. Now they're a 7. I think that them being able to see that, it kind of reminds me in a way of the pediatric respiratory score that used to be, really relevant. It was a standardized assessment and it scored out. So, everybody kind of knew where that patient was.
Mhm.
And I mean, I think that that is really a good idea to making sure that, you're making a decision in a reasonably quick amount of time. You're not dragging that out.
Yeah, and
So
then
here's the question, right? So in the meantime, who collects this data? So we need to come up with our own dashboard, our own subset of data collection to start validating the value that we bring. Because at the end of the day, same thing like when you have a patient experience, we have all those scoring from for patient facing, but they'll tell you, well, respiratory doesn't get it. But we actually part of the whole care plan, part of the whole care team. So do we now work with a quality department? And not every hospital have quality team and quality
Right.
department. So who's gonna help a small artsy department who is watching this podcast and was like, man, it's all great, but we how do I collect this data and how do I interpret this data to show that we are valuable?
Mhm.
go to the departments that are already doing it.
Yeah. I
I
mean, if
mean,
you have an electronic medical record, I promise you, like,
Somebody's doing it.
yeah,
somebody has a dashboard that probably has some of the data that you yourself are needing to have, like care
yeah.
coordination, for example.
Mhm.
Care coordination is going to have length of stay. They may even have vent days. Like they are all over that. So, it could be that you're just going to pluck some of what is, already in existence on somebody else's dashboard onto your own.
But
I
I
would
think it's
encourage people
important to
look over
show
your
where we are on that dashboard. I mean, that's the thing. If they're already doing it and there are, so I can go online right now to cms.gov and I can pull every single hospital in the United States' ER length of stay data. Every one of them. I can look at their COPD readmission data. It's live, right? Why? So if you find out who's doing it, it's also that's the perfect opportunity to say, hey, respiratory, we are absolutely contributing directly to the success of that score. We need
yeah,
to be involved in this.
yeah,
It's not
Mhm.
just about finding the person that does it. It's also about
right.
speaking up for our place on that dashboard as well.
Yeah, and I mean, and asking to have something built. I mean, I promise you that Everybody now is on the electronic medical record. There is a way to get data. I mean, for sure, because more than, just respiratory therapy has to keep up with those metrics.
Yep.
John, you said something on the first episode, and I need to find that clickbait and repost it. Most dashboard on for the RT department shows how busy we are,
Mm-hmm.
but not how effective we are.
Mm-hmm.
So I'm gonna shoot some metrics, and you could tell us, or Kerry could jump in as well. How can we shift the mindset of that metrics to show, instead of showing how busy we are, and convert that conversation to how effective it is? Like productivity. How can a leader now see productivity on more of being effective instead of being busy?
Length of stay.
Yes.
I have an RT driven protocol that I'm being productive. I have the volume, if you will, of that says this is what my RTs are doing, right? So we're not substituting volume, but where I bring value into that is to say our respiratory driven protocol keeps patients from getting stuck on the floors.
Yep.
Instead, your therapy is contributing to a next step and a next step and a next step. I mean, imagine if we did resuscitations the way that we practice respiratory care. Patients would never get chest compression stopped. It just keep on going, right?
Going.
Yeah. Instead, it's like there needs to be I've done this, I'm moving to this. I've done this, I'm moving to this, right? There's an assessment at the end, not at the beginning, at the end of what we're doing that then leads to the next step, right? Do I rapidly need to progress or elevate care, or is it time to start de-escalating care? Don't let the patients get trapped in treatment world. Instead, have throughput is the focal point of everything we're doing. Like what are you doing right now that is going to lead to the next decision, next step, the next discharge?
Because I think clinical stewardship
Yeah.
needs to
Yeah.
be, needs to be the goal. And, you know, I think that's so true.
I think I could see that for acute care. How is that conversation translating to the ICU? This is where our heaviest productivity numbers are, the heaviest weight of what we do.
Vent days.
Do we want, do we, so now again, going back to it, do we want to have less vent days?
I mean, I think less ventilator days, reintubation rates. I think the focus, once again, and I think this is everybody that's trying to lean back towards the tasks because you're thinking, man, I need this volume. I need this volume to justify having staffing. But I think that everybody is forgetting that, if your value is in what you're doing and how well you're doing it, then it becomes less important to justify people for tasks because now you've demonstrated value and outcomes. So I'm going to say your favorite thing. Your return on investment becomes having people that can do these things to improve your outcomes.
Anyway, I think I think
Hmm.
I think I think we can bring some reality to this too, right? I mean, if we start initiating protocols that have RTs, evaluating ventilator weaning readiness, I don't think that we're going to have all of a sudden a magical reduction in ventilators,
No, there's
right?
going to be events. Yeah.
Yeah, there's gonna be events, right? I do think that what this will do is this will help eliminate um, uh, non-productive productivity.
Yes.
We'll
Say that again. Say that again. Say
I
that
think
again.
I think that what we're trying to do here is not focusing on limiting or reducing vent days. It's great, right? Ventilator readiness and weaning readiness evaluations are great. I think really what we're trying to do here is to help standardize a way to prevent non-productive productivity.
Yes.
I like that.
Yeah,
Non-productive
yeah.
productivity.
So
There's
we'll
an
take,
end to that.
yeah. I mean, we'll take chest percussion for an example, right? CPPT. I know at one point we eliminated it as an airway clearance therapy for non-bronchiectasis slash non-CF patients, right? And we focus more on airway clearance techniques, getting the patients up, being more ambulatory, and we eliminated chest percussion because it's not doing anything. The patient's on a ventilator, it's not doing anything.
Right.
And that was 153 hours a week that was eliminated in RT volume, like work productivity stuff. But what happened is productivity didn't go down because it opened up opportunities for RT to run ventilator weaning protocols. It opened up opportunities for RTs to be available for CT. It opened up opportunities for more airway clearance evaluations to take place.
I think
It opened up opportunities
yeah.
for respiratory therapy to be where they belong, and that's in rounds in the ICU.
Yes. Yes.
They're so busy doing non-productive productivity tasks that they're not participating in rounds where all these true decisions are being made, where
Yeah.
our value can truly be heard, right? I mean, I don't think that a physician's job or a nurse practitioner's job, or we'll take nursing. I don't think a nurse's job is going to be at risk because they're a one-to-one assignment in the ICU.
Hmm.
They're on a one-to-one assignment in the ICU because the patient warrants a one-to-one assignment in the ICU,
Yeah.
right? So, one nurse may have one ventilator patient in a shift, but why does respiratory have 14,
Right.
right? Because it's just, well, they're just going and doing vent checks. That term drives me crazy, right? It's that you got to go back to assessing ventilator patients, right? You got to go and your respiratory therapist should be full of weaning, evaluations of weaning. And I think this is where there is some collaboration with nursing and respiratory.
Mhm.
I know that the ventilator weaning protocol, back when I saw one time that the nursing had a ventilator weaning readiness evaluation. It was separate than the RT
Mhm,
departments. I was like,
mhm,
stop,
Yeah.
time out here for a second, right? So what happens is if the nurse is not on the same page as RT,
Mm-mm.
it's postponing ventilator weaning readiness, right? If RT's over here weaning the rate and the RT's down over here running their protocol and the patient now is on a CPAP pressure support, but the nurse has it started dexamethasone, so now instead of extubating, now we're waiting, right?
Mhm.
So instead, I think there is times that I think that this will be important that respiratory takes the bull by the horns and does drive some things on their own to show their value. But I do think there are certain situations, particularly in the ICU, where a good, strong collaboration and partnership of RN RT is invaluable.
mhm,
CU
mhm,
mobility is a huge
Yeah.
quality measure that is will, speed up patients healing, faster than anything. I
Yeah.
mean, we know that. Like that's an incredible thing to be able to do. And but like you said, if you're doing unproductive work, then where is time for things like ICU mobility? Because that takes, moving a vented patient takes respiratory therapy.
Yep.
So, then you can't focus on the true quality things. I agree 1,000%.
So should a leader now, looking at this, start playing, being very smart inside the box and see how to redistribute or reclassify non-productive, productive work
I think that
to allow us to have the time for what truly matters? How, and because you still have to color inside the lines that our organizations are
we
putting,
do.
we do. So how do we navigate that? Do we need to partner up with the finance team? Do we need to partner up with the revenue team to see, okay, if we shift the weight from such and such to allow us to carry the productivity that we have, then could create the time, like going to rounds, for example. Till this day, rounds is just artsy time, which doesn't give us any doesn't show the value when it comes to productivity.
We
There's a
do
lot of stuff that
have
we
our
do that is needed,
yeah.
but we just do artsy time for it. Early mobility. So how can, or is it something that our field needs to start coming together. So, okay, those are the new standards that we are doing that we need to now impose on the finance committee. How do we get there? Because it needs to happen. How do we get there?
So before we even talk about headcount, because I think when you start approaching C-suite, that's automatically the assumption. So before, take all of that out of the equation, and I'm going to say the thing that is probably going to fire up the respiratory community. But yes, clinical activity time matters, but so does workload distribution. And if your clinical activity time or your RVUs are not appropriately weighted, you can have patients that are high acuity with lower clinical activity time or RVU counts that really take up a lot of time. And you can also have the reverse situation. You can have, you know, high cat counts and not really very much work. So, if you have a therapist in an acute care area and, say you have, I don't know, 6 BIDs and, of that 6 BIDs, 2 of those are Q6. Well, your first round is going to be a little bit heavy, but your second round, like on day shift and night shift, there's 2 treatments or 2 therapies. So what is that person going to do for the other 8 hours or, 9 hours of a shift?
That's the reality. That's what
That's
we're
the
facing.
reality. So, like, at that point, can you redistribute the workload? Can that person now go to the ICU to help transport patients? Can they participate in ICU mobility? Can they, help out or, do HOMO 2 evaluations to discharge patients? I feel like not that everybody has to be busy every second of every shift. That's not good either. You don't want to make people feel that way. But I think realistically looking at the workload distribution is something that we have not done. I think we have blindly trusted a number and we have added or taken away staffing based on that one specific thing without actually looking where is the work and what is the work.
Mhm.
So, I think that needs to be taken into consideration before headcount because you may look at your workload distribution and say, man, I may not need all these people on this shift, or I just think that stewardship alone is important because that demonstrates trust when it comes to resource allocation. And you
Mhm.
want to show your administrative team that, you are using good judgment and you are exercising stewardship when it comes to staffing resources. And you don't want your therapist there just doing low value or unproductive work just to have them there. That's not benefiting anybody.
Because as clinicians, what are they thinking needs to happen when you go into value base would be if to make sure everybody get the right treatment, the protocol, the assessment, the early mobility. If it calls for 50 therapists on a 12-hour shift
Mhm.
to create the value, that's what we need to do.
Right.
That's the expectation from the clinician.
Mhm.
Realistically, that is not gonna fly
Right.
with any C-suites. If we're gonna say that you're on the floors and you have that's not gonna fly. But
No.
so that was a good point. Workload distribution.
Yes.
That's very important. So how do we shift it? But also we've been in we in this seat now, Carrie. We talk about this all the time.
Right.
And when we used to work together, and as our role, your role as supervisor, my role at times, as RTs, we are very rigid into being flexible within that 12-hour shift.
Yes.
If you are giving that floor, we are extremely rigid to say, hey, like you mentioned it, I could now start doing home O2 evals. Or I could, because right now we are still task oriented.
Mm.
We are given those, that's the stack of paper, and we're just gonna focus on that.
Yes,
That was a very good point. That was a very good, but it's also gonna be hard. That's a culture that we need to shift from.
it is, and and it's hard for, and I can speak from experience here. It's when you start shifting that thinking, it is hard for teams to accept that that's what you're doing. And, then this is where the conversations about, readiness based versus volume based areas become important, because you can't really reliably flex from a readiness based area if that person is sharing a volume based area, if they're having to be, spread out to that area, because inevitably if you flex somebody, you're gonna pull from your readiness based. But once again, these conversations and these points are much easier to make when it comes to resource allocation with finance if you've just proven, well, I need for this person to not be in productivity numbers because I cannot flex them. It doesn't matter if there's 0 patients or 1,000. Like, I cannot get rid of this person today. You know, if you can show why, it's a completely different conversation.
Yeah. So we definitely have more work to do.
Yes.
There's a lot more work to do to get us there.
Yes.
John, what you got for us, man? What are you thinking about?
I mean, I just think the biggest thing is us stop defending status quo.
Yes. Lord, yes.
I mean, these conversations eventually just got to be focused purely on empowerment of not where we are and what we do. I just feel like we get stuck a lot of times defending what we do,
Yes.
like while respiratory belongs here, right? But instead, like we need to move past that. It should already be a given, right? We need to focus more on what would happen. Like what would we do if in 10 years we look back and we say RT is twice as um you know your level of performance is twice as valued in 10 years than it is today, right? What would that look like for RT, right? And moving towards the provider, the practitioner mindset of, we don't have to have a master's degree or an advanced practice degree to do a very good job at the bedside, right? So I mean, that's just kind of where I sit in a lot of these things, and what the opportunity is in front of us is that it's literally a boost to the net completely next level and where we honestly belong as a practice already, and it just kind of provides us to have the embracement I think needed from the key decision makers at the hospital to fully understand that.
Wow, that's a lot. That's a lot. Um, we need to find a way to recap everything for those leaders as we try to close this. If you had to give three advice to a respiratory therapy manager, director, shift supervisor, somebody who is in a position of power to make change, to move the needle slowly towards value base, what would those tips be?
I'd say empowering your clinical team to work at the top of their scope, sharpen their assessment skills, and trust their capability, trust what they know. I would say to look beyond productivity reports, start asking the question of what what is value? What is the value that, or what are their issues that hospitals are trying to solve, and how can we contribute to that and add value to that? Um, Gosh, those are the big ones, and dashboard metrics for sure. I would definitely encourage everybody to pull for that. Maybe before anything else, see if you can pull together some kind of dashboard metric.
Mhm. How about you, John?
Is your department a reflection of you?
Yeah. Oh, yeah.
John, we're trying to wrap this up.
Runs.
I guess us. Go ahead.
No, I'm saying you're asking the questions, right?
Yeah.
I mean,
Mm,
you
mm,
want to
mm,
think you
mm.
want to think about this as you're saying, hey, what are some questions for leaders? Right here we go. Is your department a reflection of you? It's got to stop. It's got to start somewhere, man. If you want a progressive, critically thinking, autonomously driven respiratory department, you have to be empowered as a leader to be the exact same thing.
Yep.
Mm,
Amen.
mm, mm, mm. That's things, man. That's things big time.
No, I mean, at the end of the day, this is not really. I mean, do we need to really honestly be sitting back having a conversation of justifying whether respiratory care is important or not? Of course it is, but why? Anybody and everybody that's in a leadership role, ask yourself this question and be able to answer the question. Sit back and think about why you are important. And I think ultimately, a lot of times we find ourselves kind of going back to why we chose to go into respiratory school in the first place. Where
Mhm.
did we become so non-complacent, right? So, at the end of the day, like you came out of school and you just kind of got stuck in a rut. That's fine; it happens. But like, if we're talking about moving forward, we gotta stop paying attention to back there. We gotta start focusing on what's in front of us. And I think
Mhm.
the easiest way to do that is to ask simply, is your department a reflection of you? And if it is, the things that you want to fix, you also have to be the driver of those changes as well.
That's good. That's good. Let's close with those rapid fire questions real quick. What is one outdated artsy practice that we need to stop tomorrow?
Task driven productivity.
I kind of knew that was gonna go there. How about for you, John?
I mean, like, yeah,
One outdated practice that we need to stop tomorrow morning, if we can. We have the power to say we're not gonna do this again. Which one it would be tomorrow morning for us to stop doing?
Ventilator checks.
Okay.
that's John's trigger word.
Hey man, look,
Yeah, yeah,
I
yeah,
need
yeah, yeah.
I need patient ventilator assessments, man. I don't need checks. All right.
Yeah,
And then look, these ideas and these things we're talking about, they start with changing the way people think about what they're doing.
absolutely.
If you're hearing
Hmm.
check, 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 that's what you're gonna do. Check,
Right. And
right?
other disciplines do too. And I've
Yeah.
been thinking about that, and I'm trying to change my verbiage as well.
Yeah. Just change the way you think, change the way you talk, change the way you carry yourself, right? That starts with what you're doing. Imagine Hans, imagine if every one of your RTs went in tomorrow and said, I got 12 ventilators to assess this morning. How pumped up would you be as a leader about your department if that's the mindset and that's the way your staff
Mhm.
talk?
Hmm.
Yeah.
What is one metric every RC leader should know or start paying more attention to?
Start paying more attention to
Hmm.
uh,
Ventilator is.
ventilator days. You
Mhm.
said, yeah. I mean, I think I think total length of stay is a big one, especially in the balance between Medicare and Medicaid. I think especially in the days we are in now, where there's been such a massive Medicaid cut that's happened, length of stay is going to be an invaluable number that we have to focus on because once that they exceed those that 72 hours, it becomes now back up for negotiation of what that reimbursement is going to look like. So I think building and structuring protocols and activity that help drive length of stay and shorten the total length of stay, all that's going to do is just help highlight where respiratory is bringing financial value to the hospital.
And I mean, if you
Hmm.
take a deeper dive into that, obviously we impact length of stay, in a big way, but there are also variables there that are kind of out of our control. So, once respiratory as a service line kind of comes off or the patient stabilizes back to their baseline, you know, how long between that time and the time the patient actually discharges from the hospital?
That's a really good point. So you're talking about when the
Mm-hmm.
COPD exacerbation is at baseline, but they still have 2 plus pitting edema, right? So
Yes.
they're still doing fluid diuresis management, right? Does
Yes.
respiratory potentially fall off of the capture once they're at
Mm-hmm.
respiratory baseline? But then I think that's a great point, Carrie. Honestly, yeah,
It is.
yeah.
What is one prediction you have for the field within the next 10 to 15 years? Are we going to make it? Are we going to be progressive? Or are we at risk of seeing some stagnation in respiratory care?
Well, I'm going to speak positively into the world. I'm going to manifest this. Um, I think that, and I hope and pray that respiratory will not be known for what they do, but for the decisions they make and the outcomes they impact. That's what I want to see.
How about you, John? What do you see the field in the next 10 to 15 years?
Yeah, I mean, I would like to just say, man, I would echo 100% of what Carrie just said, right? The Where I would like to see things move towards is that there is kind of a holistic embracement from the field to want to be better, right? And that respiratory is a respiratory practitioner mindset,
Yes.
uh, workforce at the hospital where we're getting called for consultations, not called for treatments.
Yep.
Hmm.
That's
Well,
ultimate.
team, we did again. Yeah, that was great. So to wrap this up, right? I think what I would tell any leaders right now as we're trying to move from volume based to value based, one, is going to be difficult.
Yeah.
It is ingrained in us.
Mm-hmm.
Vet checks, treatment count. We are count task driven oriented. It's ingrained in us. But like John said, to all my leaders, the department should be a representation of you, should be a representation of me. And actually, this podcast is now firing me up to go back and do better, firing me up to go back and see how can we now change the culture, change the approach. Kerry said a lot of both of all of us. The conversation was great because Kerry talked about workload distribution. We do have the numbers, but if we're not distributing it the right way to allow us to within that 12 hours to provide, like John said, a holistic approach to the care that we give to bring value within those 12 hours, we're still going to be stuck into a task mindset mentality. This was a great conversation. There's not a better way for me to close session one, volume based versus value based. And definitely, Carrie, John, thank you for your time. We will talk soon.
Thank you,
Thanks
man.
so much, guys.
All right, thanks.
Bye.
Bye.